Okay, hi everyone. We have Dr. Patel joining us, which is awesome. So I just want to get started.
I clicked on the wrong link.
Oh, no problem. I'm sorry about that. So I just wanted to, start off saying hi and thank you to our panel. Thank you to the audience for joining us today. My name is Kanisha Gala, and I'm the project owner handling our clinical panel series here at LARVOL. And I'm just going to start off by introducing our panel. So with us today, we have Dr. Kevin Nuff as moderator. He is the Chief of Hematology Oncology at Highland Hospital and also an assistant professor of clinical medicine at UCSF. Our panelists are Dr. Sandip Patel, who is the Deputy Director of the San Diego Center for Precision Immunotherapy, and also the Assistant Director of the Clinical Trials Office and a member of the Thoracic Oncology and Cancer Immunotherapy Program at UCSD, and Dr. Balazs Halmos, who is the Director of Thoracic Oncology, Director of Clinical Cancer Genomics, and also a Professor of Medicine at Montefiore Health System at Albert Einstein College of Medicine. I want to say to our panel, thank you so much for joining us. We're really, really excited to hear from you and discuss the impact of the 3 abstracts we've selected today. So with that, I'm going to hand it over to Dr. Nuff. Thank you.
Thank you. So these are 3 very, very interesting abstracts. It was a very interesting year for lung cancer. So let's start with the first abstract, the Empower 010 trial. Dr. Patel, can you tell us a little bit about this study?
Yeah, I thought this is probably one of the more provocative, if not the most provocative. And it seems like every year at ASCO, we have one adjuvant study in thoracic oncology that captures the imagination and potentially the consternation of the thoracic faculty. And so what this study was looking at atezolizumab, an anti-PD-L1 antibody, as adjuvant therapy after surgery, after chemotherapy for stage 1B to stage 3A non-small cell lung cancer. And it actually had a pretty complicated statistical design. It was a nested, I think 4 or 5 hierarchies in terms of how survival was measured. But the initial disease-free survival, not yet overall survival, but disease-free survival for PD-L1 TC greater than 1, and I'll explain that in a bit more detail in a second, was positive compared to the standard care of surgery followed by chemotherapy in terms of disease-free survival. Now, I should note that PD-L1 was measured in the tumor cell compartment only using the SP263 assay. Those who practice in thoracic oncology spend a lot of time talking about the DACO22C3 and may have heard that the atezo SP142 may have had poor staining. This is using a different antibody clone called SP263, which is more similar to the DACO22C3, where we're more familiar with. We also saw some initial data for overall survival. It's premature, as you see here, but a trend, though a lot of censoring at the right part of the tail, for the PD-L1 greater than 1%. And so, one of the other key questions we didn't see, and this actually is reminiscent of some of the questions around Keynote 42, though at the plenary, they presented the 1 to 49% data for PD-L1 expression. Here, we don't yet know for a patient with PD-L1 expression between 1 to 49% where their benefit may lie on the spectrum, because the data was presented for greater than 1% and greater than 50%, but the 1 to 49% aspect remains unclear the benefit there remains unclear at this time.
Yeah, this is very intriguing, and adjuvant lung cancer care has gotten much more complicated in the past couple of years. What do you think about applying this, or is it just something to keep studying for now?
Well, I think this is probably going to get submitted to regulatory bodies, and I think like ADORA, this will probably be something that will be available before we have overall survival.
Right.
We may hit OS in greater than 50%, but the 1 to 49, depending on the event rate, we don't know yet. It may take longer, and it may be like ADORA, where we're kind of flying half blind, right, in terms of the benefit. And so I do think that for greater than 50%, this makes a lot of sense, especially if you have higher stage, higher PD-L1, atezo becomes more attractive. The lower your stage, the lower your PD-L1 score, it becomes less attractive. And I think one point to make is there was a 0.8% immune-related adverse event fatality rate right? And so this is not risk-free.
Right.
And while you can get low-grade IRAEs, the fact that we had fatal IRAs, I believe there were 2 cases of pneumonitis and maybe 1 of myocarditis. We can discuss afterwards the details, but
Right.
the idea that this is curative intent therapy, right? And so the risk-benefit ratio, especially if we don't have OS, we have to be very vigilant. And so my sense is the higher the PD-L1, the higher the stage, the more the benefit. The lower the PD-L1 score, the lower stage, the less the benefit. But we have to weigh that against a non-zero risk here, in my opinion.
Yeah, that's a very good point. Dr. Halmos, are there patients you'd feel comfortable prescribing this for, assuming it's approved regulatory-wise and reimbursed?
Yes, most definitely. I think most of us felt that this was one of the biggest breakthroughs at ASCO this year. It should have been a plenary session presentation. It's a huge unmet need. Patients, especially with node-positive non-small cell lung cancer, have a 70-80% chance of recurrence, and we have better treatments for them now than in the past, but still, we will lose most of them if we wait until the cancer recurs. And we've learned that immunotherapy makes a huge difference in stage 4 disease. We've learned it makes a huge difference in unresectable stage 3. So it makes a logical, leap in a way, to get into the adjuvant setting. And we also have learned that biomarkers make a difference, especially in the context of single agent immunotherapy. And this beautifully highlights, that as well, that dependent on the TPS score, the benefit is drastically different. So I think as the data matures, we'll learn better how to nuance the use of it. But if the FDA approves, and I see no reason why they would not approve it, at least for the PD-L1 positive patient population, I would definitely discuss this with my patients and most likely use it with great enthusiasm for the high TPS score patients, and less so, with lower stage and lower TPS score, and likely would not recommend it for EGFR ALK mutated patients. And of course, there will be some subsets where we have to scratch our head. What if somebody has an NTRK translocated, resected non-small cell, who knows? But for the large majority of patients, this should be part of our conversation from this on.
Yeah, I didn't actually read this closely. Was there a benefit more in smokers than non-smokers? Did they do any subset analyses?
Well, the subset analysis did suggest there was no benefit for ALK translocated patients.
Right.
Of course, small subset, but makes a lot of biological and clinical sense. For EGFR, something similar was noted dependent on which, subset analysis you look at. But we also have the ADORA data, so most likely most of us will be discussing that instead.
So
One great point is, we try to do smoking cessation as part of the preoperative workup, right? It's PFTs, and we know the outcomes are poor for current smokers. One of the most interesting things about this paper, and I agree that this is very likely practice changing, and this likely would have been a plenary, in my opinion, was that if you were a former smoker, you got a ton of benefit out of Atezo. If you're a never smoker, you didn't get as much benefit, but if you're a current smoker, there was almost no benefit to Atezo, which is very paradoxical. The hazard ratio is actually right at 1 for DFS. And so this just shows, sometimes the softer side of what we do in oncology has as big an impact. Getting people to quit smoking during their preoperative period not only helps them recover from their surgery, reduces their risk of ventilation, complications, chest tubes from the surgery itself. If we are going to adopt an adjuvant strategy, it actually improves their long-term survival. And so a very cost-effective way of improving their outcomes is to get our patients who are smokers to quit in their preoperative period.
Wow. And it will actually improve their outcome, not just from the smoking cessation, but if they get this drug as well in the adjuvant setting.
Absolutely. For reasons that are not clear. Yeah.
Yeah. Okay. Any problems giving this medicine? I mean, I think we're all comfortable with giving PD-1 and PD-L1 inhibitors to our patients, so it's not a new drug or something we're not used to.
Very, very comfortable, but of course, there's patients with different, comorbidities, autoimmune disease, where it will be a little bit more difficult to make the right decision. So definitely, we need to keep using the art of medicine in a way in our practices.
Right. Well, we've had to become better at endocrinology and cardiology and some other things with this class of medicines coming on board. It's kind of fun to do more internal medicine thinking sometimes. How about the second study, Dr. Halmos, the 9013 of aumolertinib versus?
Yeah, very, very interesting study. This is a phase 3 randomized study from China comparing this irreversible third generation EGFR TKI aumolertinib against gefitinib. And in a way, it seems like copycat study, to flora. And in reality, if you look at the data, it almost matches it, down to the fraction. Is there an unmet need, for another third generation drug? Well, there's no specific unmet need because osimertinib is an excellent drug. There's an unmet need to build on osimertinib, and there's an unmet need in terms of,
Maybe is he frozen for you guys too?
Yeah.
Maybe while we're waiting for him to unfreeze, oh, sorry, good.
Can you guys
just
hear me
unfroze.
okay?
Yeah, great.
You just unfroze.
Okay.
You unfroze for about 15 seconds.
Okay, sorry about that. The data was warming me up, not freezing me in a way, but a randomized phase 3 study, comparing these two drugs, and certainly showing dramatic benefits of this drug against gefitinib, to the point that the hazard ratio of 0.46 in a large, well-done randomized study. The hazard ratio is even better, when you look at patients with CNS disease, exon 19 deletion. So everything really matches the flora data. And the big promise here is a price gain as compared to the current standard of care, osimertinib. And I will be very curious to see how U.S. physicians and insurance companies and guideline, managers, in a way, pathway, managers, we look at incorporating this. This is not a generic, this is not a biosimilar, this is a different drug, but in a way, shows exactly identical data. So if it's cheaper, why wouldn't we be using it?
Well, you're saying it'll be priced less than branded OC, because right now we have branded OC and generic erlotinib. You think it'll be priced somewhere in those two?
Of course, we don't know, but that's the statement that we're hearing. And of course, in certain countries, this will be huge. Where osimertinib maybe is not approved, or it's approved, but the population is unable to really utilize it. In the States, we're very comfortable as doctors. We can get these medicines to most of our patients, but we're spending a huge fraction of our money is on healthcare and expensive drugs. So we need to be somewhat prudent, I think, in our decisions. So I will be very curious to see if it comes to the U.S. market, how we look at it. But I definitely could foresee some utilization.
Right, but Dr. Patel, it's been compared in this trial to gefitinib, which we don't use much in the U.S. anymore. How would that make you feel about using it in clinic if it were approved?
Well, I think using it in clinic, this is, a kind of a copy of the flora design. It would really be in a nuanced scenario. I mean, the other point to make about elmoritinib is if we look at the toxicity data, it actually looks a bit more like brigatinib than it does like osimertinib, right? So it has CPK elevations, some LFT elevations. So it's a bit different than OC, which has more GI and cutaneous toxicity. And so the toxicities would play into this. But I think, in the US, there are two levels of cost, right? There's one to the health system as a whole, but then the other is the out-of-pocket cost to the patient, right? And I think most of us are directly sensitive to the out-of-pocket copays for the patient, because that's the person in front of us. And then there's the more kind of societal view of cost structures as well. And then the other point to make is there are ongoing studies looking at amivantamab and lazertinib, and there's some interesting data from that combination in the post-osimertinib setting, now in the frontline space. So I think it's going to be a very complicated space to be in. There are trials of chemo plus OC, anti-angiogenic inhibitors plus third-generation EGFR inhibitors. And so I think it's actually going to get less clear before it becomes more clear.
Right.
It's always nice to have more choices. So I think it's welcome news in a way for the field. And I'm surprised it didn't get more noise at ASCO. I mean, this is the randomized phase 3 study. It deserves some attention.
Yeah, I thought the lung studies were actually interesting and underplayed at ASCO as somebody who's a generalist. So we are just sort of
used to it.
Lung became very, very interesting compared to 20 years ago when I trained. I mean, we had cisplatin and Taxol.
But if we took the IAPower O&O data, right, and I replaced it with breast cancer drugs, not only would it be the plenary, it would be front New England Journal, New York Times. I mean, if I took the exact same study and just replaced it with triple negative breast cancer, it would have, plenary on the cover of ASCO News. There is a difference.
Right. Well, ASCO does not have a separate lung cancer conference the way they do with breast or GI or GU, right? doesn't get as much respect.
I think it's lacked. Yeah. No, but I think there are some differences, and there was a really nice social media post comparing the Olympia study to Adora. So I think there are some inherent differences in how similar data are discussed amongst various disease-specific groups and also just broader entities. Not that it's on ASCO, it's just the interpretation therein really belies kind of the social media context in which all these studies are discussed.
Right. Well, that would take us to a sociological discussion about lung cancer and why it doesn't get as much press. But obviously, where we are here in Northern California, at least half of my patients with lung cancer are non-smokers. So the stigma attached to it makes no sense at all. What would you say in terms of sequencing EGFR inhibitors for patients who are not on trial? Most people start with OC and then have what left? I mean, would this be something to be used before OC or?
No, I think it's about replacing OC, providing an alternative for the unusual patient who cannot tolerate it for whatever reason. It's cost, containment. But we've seen a lot of interesting data post OC at ASCO, actually. With the antibody, based molecules, the anti-HER3, and the other, the amivantamab. Both molecules have shown significant activity. So there will be some strong players in the post-ASCO space besides just chemotherapy. So great ASCO for that as well.
Right. It'll take a while to digest, but the lung cancer has become very complicated and, of course, has sort of led the way with the use of next generation sequencing and looking at molecular differences. And so it's not getting the respect that the trials command. I agree. How about the third trial, Dr. Patel, on selective RET inhibitor? This is just a target we didn't know about a number of years ago, and now we're looking for it in lung cancer.
Yeah, we're about to have probably more drugs approved for the treatment of RET than most thoracic oncologists see patients with in a year. I mean, it's a very rare subset. So if you treat thyroid cancer, maybe you see this a little more, especially medullary thyroid cancer. Lung cancer, of course, is so common, but it's a needle in haystack problem, though this comes along with your NGS. So BOS 17278, I'll just call it 738 from here on out, is a next generation RET inhibitor similar to salpercatinib or pralsetinib, which are both FDA approved, which these are really actual RET inhibitors, right? Cabozantinib, vandatinib, they just incidentally hit RET, but hit every other kinase along the way, and that explained their side effects and their lack of efficacy. So here, there are multiple cohorts in this study. This is the non-small cell cohort you show. Really nice waterfall plot. When you look at the objective response rate, it's actually a little lower than in like the libretto study and the pralsetinib study. But part of it is if you actually look at the waterfall plot, you have a ton of patients who have shrinkage, but they haven't crossed the 30% threshold. So, if you look at a larger study, I wonder how similar all these drugs would be. This is very reminiscent of the discussion we just had about having another entry into this space. This would be, the third quote unquote next generation RET inhibitor if this data pans out. We see a slightly different side effect profile, CPK increase. It wasn't as clear to me if this was ever associated with bona fide myositis. We see muscle weakness at about 19%, right? So is the 19% muscle weakness a subset of the 60% that has CPK increase? And did they get myositis? That kind of thing, and some LFT abnormalities. But overall, it looked reasonable. There's a cohort of patients who will be post salpercatinib, post pralsetinib. That's cohort 3 in this study. That I actually think that's the cohort that'll be of interest, right? Is there a reason to think this may help us in a subgroup of patients that have a resistance to these other next generation agents? But overall, I thought this was an interesting compound and may add to the armamentarium. I don't see a clear immediate role in the frontline space because we already have 2 drugs there, but maybe over time and maybe when we look at the different adverse events, we see some other issues, especially like hypertension with some of the other agents and edema. This seems to have less of that and more of the muscle type aches. But I think the cohort 3 is really what I'm interested in seeing, which is the post salpercatinib, post pralsetinib cohort.
Right. Dr. Halmos, do you have a favorite RET inhibitor that you're using first line or?
Yeah, I mean, the drug is nicely called BOS. I was like thinking, is this going to be the BOS of the RET field? But I'm not sure yet. The response rate is a little bit under-impressive as compared to approved compounds. And we didn't get much detail as to any very specific biochemistry, acquired resistance. There was a mention about gatekeeper mutations, but the very specific ones that have been noted after, saprocatinib or prasetinib, I didn't find any indication that the drug would be active for those. So I agree with, Sandip. I think that cohort will be key to be able to show that in certain subsets post, the two FDA-approved compounds, this will have some activity. Otherwise, again, it's just nice to have more molecules, but it will have a hard time, replacing the two dominant players in the field, in my mind.
Will you have enough evidence from a phase 1 trial to say in that third cohort that this drug is effective as a second-line RET inhibitor?
No, and the percentages could be off, as we expand the experience, but also in reality, there's so few patients that, I feel for these companies, because finding patients now will be very difficult in a way, because those patients are on either one of those two FDA-approved compounds. So it's hard to, get more drugs in such a small subset of patients being developed, but, certainly it's nice to have, more drugs out there.
Right. Well, I think most oncologists know they should be doing next generation sequencing in adenocarcinomas. Are you seeing that this isn't being done in patients, or like you seeing that?
Well, there's a report at ASCO, right? They actually looked at a very large East Coast group, and I apologize, I'm blanking on the name off the top of my head, but it was only about 60% of patients were getting next generation sequencing. And this is just from the most recent ASCO. And that's a well-organized group where you can collect the data, right? The places you can't even collect the data on who's getting NGS or EGFR, that's the places that are likely even lower, right? Because they don't have the data to collect. So it's a little bit of ascertainment bias. But, it's just really hard because you can do it in 2 tubes of blood nowadays, right? It's just, you don't need tissue anymore. You could get all the answers in 2 tubes of blood, and it's just really it's frustrating because we have the other thing we haven't talked about before ASCO. We had the approval of a KRAS G12C inhibitor, right? Which really is a landmark in the field, right? It's been 2 decades, maybe 3 decades in the making. We have all these great precision therapies, but if we don't look, we can't use these therapies appropriately. And it's not cheaper to, not order the test and give IO, where IO is expensive, it doesn't work and cause autoimmune toxicities. So it's really a challenge. And I think understanding the root cause in some of these practicing groups on why it's not being ordered, because it's the same as not ordering ER, PR, HER2 in breast cancer. It's just almost unheard of.
It's become that way. And I don't know, the Flatiron database about people not using EGFR inhibitors was very shocking to see. You can't get the drugs approved unless you have NGS evidence, right, of the target. Nobody's going to approve these drugs.
Definitely room for improvement in terms of testing. And now we have 9 actionable markers, with the KRAS inhibitor being approved. So we absolutely have to do it for our patients. And I think with Empower 10, the same thing now applies in a way to early stage. Precision medicine is here to stay for early stage lung cancer as well. With ADAURA, we could say, we'll just test for EGFR. But now, we will need to, really think about testing for ALK. Absolutely need to make sure we have PD-L1. And I think, that list will continue to grow in the coming years. So precision medicine is here to stay from stage 1 to stage 4 non-small cell lung cancer for sure.
When you say stage 1 to stage 4, that's to make decisions in the adjuvant setting about targeted therapy and things like that, or?
Well, we have the ADAURA data, now we have Empower 10. So definitely, if I see a patient and I want to make that nuanced decision, do I give that patient a year of immunotherapy with reasonable, but sometimes still significant side effects? I would want to understand that patient's molecular profile if I can, at a high level.
No, we had, we're a county hospital and very cost conscious. So we had been doing IHC for adenocarcinomas lung, and then I hired some young doctors and we started doing NGS in all these patients. So I think we're at 100% here. So it's definitely doable with a little education that these patients should get NGS. While I'm asked on that topic, not related to this trial per se, but are you all comfortable with liquid biopsy to look for RET, or do you need tissue biopsy?
Yeah. I think if you can find it and cell-free, you're in good shape.
Right.
But for that never smoker or the young patient in which liquid doesn't get you the answer,
right,
I actually think tissue just because of sensitivity, but you may want to consider DNA plus RNA-based testing. Some of these fusions are better seen by RNA-seq. Memorial actually had a really nice series where they actually found, and I think about 3 or 4% of their patients, so it's obviously a unique patient population, that if they're low TMB and they weren't able to, on their initial kind of 500 gene panel, find something, they reflexed into RNA, and they found some cryptic RET fusions, and I think ROS1 was the most common cryptic fusion. And so for some of these fusion events, they're actually really hard to see by DNA-based testing and really hard to see by cell-free DNA. NTRK3, MET exon 14 skipping, MET amplifications, these are really hard for DNA-based only cell-free DNA sequencing to pick up. And so A, tissue, but B, RNA-seq for that appropriate patient. But I think it's a great screen, kind of like for HER2 and breast cancer, right? Where IHC probably gets us 80 to 90% of the time, right? We probably send reflex fish, maybe 10 to 20% of the time, maybe a little higher depending on your population. And so I view it analogously to that, at least in my practice.
Yeah.
Dr. Halmos, are you getting simultaneous liquid and tissue-based biopsies, or?
Yeah, let me expand that a little bit. But first, let me just comment that Sandip summarized it really well. In the stage 4 setting, of course, we have validated ctDNA usage both upfront, for decision making as to optimal therapy, especially when tissue is limited or where there's urgency in terms of needing to start treatment. Definitely, ctDNA expedites our ability to get to decision making, and also in the acquired resistance setting, molecularly targeting compounds. So 2 validated settings. Concurrent use institutions will differ. I think in the ideal world, it would be nice, but it's an extra expense. So we try to, streamline in a way that, we minimize wastage, but, quite a few patients will get it concurrently, not as a routine. And let me just highlight that in the earlier stage resected setting, of course, we should do tissue-based testing because tissue is available and we have time. At the same time, we will need to see the development of MRD assays. So we'll see a new array of liquid biopsy technology, allowing us to re-stratify our patients better as to their need for adjuvant therapies after either surgery or some other form of definitive therapy, such as radiation or chemoradiation.
So it should be a quality measure, at least in a non-smoker adenocarcinoma, to get full genomic sequencing. I mean, there's a mutation there if you look hard enough for it, right?
It
Even
should be like
smokers,
aspirin, right? Hospital should report, and then patients should turn away from the emergency room if molecular testing rates are not high enough.
But even with smokers, right, you can find EGFR, you can find MET, and KRAS G12C is actually predominantly in smokers. And so I think smoking history would kind of be like using age to test for ER/PR in breast cancer, right? It's kind of, it's a demographic factor that may correlate, but I think over time is less relevant. I think the bigger point is test and don't guess. And people used to say, well, the genomic testing is expensive, and it's not cheap. But giving, Keytruda or Tecentriq or Opdivo is extraordinarily expensive also. And, kind of measuring twice and cutting once, I think, is appropriate. The point I wanted to make, though, sorry if I misspoke about how we handle testing, at least our institution, is we'll order the cell-free and tissue at the same time, not with the goal of having expensive duplicative testing, but the cell-free DNA comes back in like 5 to 7 days.
Right.
So even before the slides have even made it to the sequencer for tissue-based sequencing, we may have our answer. If we don't have our answer, we're 5 to 7 days ahead of where we would be if we waited for reflex. And so the goal is not to do duplicative expensive testing. It's to streamline as much as possible time to get the molecular diagnosis, because even once you have that, you have to get the drug approved with a reasonable out-of-pocket copay, right? And that whole process could take an additional 2 weeks, right? And that's a whole month for a patient who just got the diagnosis of cancer in the frontline space.
No, I mean, we have to give 1 or 2 cycles of carbolymptus sometimes, so we're waiting for that. As referral centers, how often do you see patients who have, for second line, third line, who have had only PD-1 but nothing else for testing? Like, we haven't actually had full testing.
It's not common. I think most patients will have had at least EGFR, ALK, and RAS. I think that's kind of integrated into the mindset of the typical community oncologist. But are we sure that they were done correctly? Sometimes you find it was ctDNA testing, and if you look at the report, it turns out it was an uninformative ctDNA test, but the oncologist believed that it meant that the patient was EGFR, ALK negative. So I personally, even in my own patients, whenever I switch lines of treatment, I look back at the molecular testing we performed. Have I really done it well enough? Has there been some information gained over the year and a half, since the patient had been on maintenance treatment? So we should offer second opinions to ourselves as well as we move along in the treatment journey.
And it's a great point, right? Because KRAS G12C, you ordered the test for frontline, but you're not acting on it until second line for way further out, right? And so it is important to kind of, I have it at the top of my note, right? So it's like data service, reason for consult, right? It's their histologic diagnosis, their molecular diagnosis, and their treatment history, right? Because I think molecular diagnosis in lung adenocarcinoma is as important as histologic diagnosis in the current era.
Is there a good article on this in the ASCO educational book for those of us who need to think harder about molecular testing in lung cancer? Maybe.
I haven't gotten to the ASCO educational book yet. Sandip, are you a more avid reader than myself?
Yeah, I've actually haven't, normally we get these, when we check in, right? And we kind of flip through them. And one of the things about virtual is I'm going to have to track down that PDF and flip through it. But it's a great point. I think that the simplest message I can give, though, is if you order the test, the annotation will tell you the right treatment, right? So whatever vendor you use, even in-house, if you have a KRAS G12C, it's going to say sotorasib, right? If it has, EGFR, it's going to say osimertinib preferred and list all the others. So if you remember to order the test, what comes in the appropriate setting, what comes next is actually a little more natural. I think this is maybe a reasonable point with the question. I just wanted to make one point that PD-L1 is a bit of a red herring, right? So you can have a PD-L1 score of 80% and have an EGFR mutation. Your PD-L1, though, will come back in 48 hours. Your EGFR test may take 2 or 3 weeks. And so, like you were saying, Kevin, I typically, if I'm behind the 8 ball and I have to treat because they're in extremis, this is a great time for radiation, right? If you have to take care of any painful issues, any CNS issues. But also, I'll give a cycle of carbopem or 2 cycles of carbopem without the immunotherapy. Because if they come back with an EGFR inhibitor, you don't want to trigger pneumonitis when you introduce the osimertinib, for example.
Right. Yeah. No, the ASCO educational book is a good resource for those of us who treat many different types of cancer to try and read what's current in each. So it is harder when it comes to the PDF rather than a book you can read physically. But
they just need to publish it as a series of tweets, it sounds like, or TikToks.
I'm still used to reading articles on paper, so I like pen to paper.
Yeah, it's a great book. Yeah.
I'm not ready to recommend a TikTok yet.
All right, Dr. Halmos, maybe next year we can get to a TikTok. Thank you so much for participating. This was a very interesting and intriguing session.
Likewise. Thank you, guys.
Thank you so much. Thanks to our panel. Thank you, Dr. Nuff, Dr. Halmos, Dr. Patel. And thank you to our audience also for tuning in. I do want to say that LARVOL will be hosting other panel discussions in oncology following ESMO and also IASLC in September. And we look forward to seeing you there. And again, thank you so much, Dr. Patel, Dr. Halmos. I learned so much, and I'm sure our audience feels the exact same way. Thanks.
Thank you, guys. Bye-bye.
You guys have a good day.